Good morning, everyone. Today's another discussion on topic is radiation plus procarbazine, CCNU, and vincristine in a low-grade glioma. So, most common brain tumor is a secondary brain tumor that is 5 to 10 times more common than primary brain tumor. And which are primary brain tumor that most common is a glioma and then meningiomas. Glioma is 30% of all the primary brain tumor and 80% of malignant brain tumors, and are responsible for most deaths from primary brain tumors. So most primary brain tumor in adult are of glial origin and that are considered among the diffuse glioma mainly. And that contain astrocytoma, that is IDS mutant, oligodendroglioma, IDS mutant, and 1p19q4 deleted, and a glioblastoma, IDS wild type. Only grade 1 and grade 2 tumor considered as a low grade glioma, but also grade 3 IDS mutant considered as a low grade glioma because of a long survival of many patients. So most primary brain tumors are sporadic and without a known cause, but glioma also arising from some cancer predisposition syndrome like basal cell Nevo's syndrome, Cowden syndrome, Glioma, neopharyngitis 1-2, tuberous sclerosis, familial adenomatous polyposis, Lynch syndrome, and VHL. But patient also develop primary brain tumor from receive radiation therapy or radiation exposure of the head and face. And the majority of these tumor after radiation, that is a meningioma followed by radiation-induced glioma and sarcomas. So, patient present with multiple symptoms, but most common symptoms include headache, seizures, cognitive decline, and neurological deficit. But headache is more common in high-grade tumors than in low-grade tumor, and that is a sign of increased intestinal pressure. But in contrast, seizures are more common in the low-grade gliomas compared with high-grade glioma. So, maximum safe resection is the first line of treatment. So early post-operative contrast in MRI should be obtained within 24 to 48 hours after resection to determine the extent of resection and to serve as a baseline for future comparison. The post-surgical management of adult type diffuse glioma is based on the histomolecular classification of and CNS-WHO grade, presence of MGMT promoter methylation in IDS wild type glioblastoma and patient age, and performance status and neurological condition. So glioma are a heterogeneous group of tumor that are diagnosed according to their histological feature and different molecular biomarker as defined by the 2021 WHO classification. So in previously 2000 WHO 2016 classification, the adult type glioma divided into multiple subcategories, and in change into WHO 2021, adult type diffuse glioma contain only 3 categories, that is astrocytoma IDS mutant, oligodendroglioma IDS mutant 1p19q4 deleted, and glioblastoma IDS wild type. So how to differentiate between oligodendroglioma and astrocytoma? So whenever IDS 1 or 2 sequencing or IDS R132H IHC positive, then ATRX and 1p19q4 deletion. If ATRX IHC negative and 1p19q is non-correlated, that is astrocytoma IDS mutant. Then divide into grade 2, 3, and 4. If vascular proliferation or necrosis both are present, then astrocytoma is grade 4. If vascular proliferation or necrosis both are negative, then we see mitotic activity. If mitotic activity is present, then astrocytoma grade 3, and mitotic activity is negative, then grade 2. But whenever considered CDK and 2AB testing, deletion is positive, that is the astrocytoma grade 4. If IDH is a mutant, IDH positive, then ATRX IHC is positive, then suspected oligodendroglioma. So we have to see 1p19q4 deletion. If 1p19q4 deletion is not present, only ATRX IHC positive and IDH is mutant, then that is a astrocytoma IDH mutant. But with 1p19q4 deletion, that is oligodendroglioma. Then we divide into grade 2 and grade 3 with other features like brisk mitotic activity, high cellularity, atypia, vascular proliferation, and necrosis. If present, then that is a grade 3, or negative, then is a grade 2. So basic treatment include the oligodendroglioma grade 2 and grade 3. So in oligodendroglioma grade 2 with a favorable prognostic profile like age less than 40 years, no any neurological deficit, low tumor, and saying that W is a grade 2, then we have to wait and watch for over. But with a grade 2 with a less favorable prognostic profile or grade 3, then we have to radiotherapy followed by PCV. In astrocytoma, with grade 2 same as a favorable prognostic profile, wait and watch protocol. With a less favorable prognostic profile or grade 3, radiotherapy followed by temozolomide, and in grade 4, radiotherapy with CPRT with temozolomide. So astrocytoma IDS mutated. So grade 2 tumor has an emerging approach, that is a patient with newly diagnosed IDS mutant grade 2 astrocytoma. You have 3 options for post-operative management. One is a watchful waiting, another is RT plus chemotherapy, and third is IDS targeted therapy. The use of an IDH inhibitor in this setting is based on the result of the INDIGO trial, that is a vorasidenib. So initial treatment is after maximal safe resection, WHO grade 2. If then any residual tumor is present in post-operative MRI, yes, then treat with RT plus either adjuvant temozolomide for 12 monthly cycle or adjuvant PCV 6 cycle. If WHO grade 2 with no any residual tumor, then observation. In WHO grade 3, we treat with RT plus adjuvant temozolomide or PCV, and WHO grade 4, RT with temozolomide. Long-term efficacy of early versus delayed RT in a low-grade glioma, astrocytoma and oligodendroglioma. In adult, that is the EORTC 22845 randomized trial. So randomly assigned 311 patients with low-grade glioma to receive either immediate RT, that is 54 grade 6 weeks, or no therapy until progress, following initial biopsy or rejection. But a median follow-up of almost 8 years, immediate post-operative RT prolonged PFS compared with the initial observation, that is a 5.4 years versus 3.7 years, but did not affect OS, that is 7.4 versus 7.2. So among patients who underwent surgery at the time of recurrence, approximately 2/3 of tumors were high-grade in each group. In the absence of a survival benefit for early RT compared with RT at the time of progression, that suggests that RT slows the progression of a low-grade glioma, but does not prevent transformation into high-grade gliomas. The phase 2 study based on a chemoradiation therapy regimen for high-risk low-grade glioma, that is a long-term result of a radiation therapy oncology group 0424 trial. That contain for this single arm study, phase 2 study, patient with low-grade glioma with 3 or more than 3 risk factors. That include age 40 or more than 40 years, astrocytoma histology, bihemispheric tumor, size, preoperative size is of 6 or more than 6 centimeters, or any neurological function deficit present. The patient receive RT 54 grain 30 fraction with TMZ and up to 12 cycle of post-RT TMZ. So the initial primary endpoint was overall survival at 3 years after registration, and secondary is a PFS. So the 3-year OS was 73.5%, numerically superior to the 3-year OS that historically is 54%. The median survival time was 8.2 years, and 5 and 10-year OS rate was 60.9% and 34.6% respectively. And 5 and 10-year PFS is 46.8 and 25.5%. So the analysis by Pignati et al. Of the EORTC 22844 trial that identified 5 prognostic factors that include age 40 or more than 40, largest preoperative tumor diameter, that is 6 or more than 6 centimeters, tumor crossing the corpus callosum, astrocytoma histology, and preoperative neurological function deficit. The patient with 2 or less than 2 of these 5 factors had a median survival time is 7.7 years, whereas patient with 3 or more than 3 risk factors had a significantly shorter median survival time, that is a 3.2 to 3.6 years. Oligodendroglioma, IDH mutant, and 1p19 correlation. So after maximal safe resection, if patient has a grade 2 and without any residual tumor, then we have to observe. With residual tumor, treat with RT plus either adjuvant PCV 6 cycle or adjuvant TMZ 12 cycles. Or in grade 3, we have to treat with RT plus either PCV or temozolomide. In oligodendroglioma grade 3, there are 2 trials. We have RTOC 9402 and EORTC 26951. In RTOC 9402, they have an intensive PCV 4 cycle followed by radiotherapy, and another arm is radiotherapy alone. In EORTC 2695, radiotherapy followed by PCV 6 cycle, and another is radiotherapy now. In both EORTC 26951, that is a European, and RTOC 9402 trial, both have showed excellent result with PFS and OS improvement. And use of PCV is supported by result of the RTOG 9802 trial in patient with the grade 2 ODG, and the 2 randomized trial in patient with the anaplastic, that is a grade 3 ODG, EORTC 26951 and RTOG 9402. So in all 3 trials, the addition of PCV to RT was associated with improved PFS and OS compared with the RT alone in those with 1p19 co-deleted tumors. Now ongoing randomized trial that is a CODEL in which patient with a 1p19 co-deletion and co-deleted anaplastic, that is a grade 3 or low-grade glioma, are randomly assigned to one of the 2 treatment arms, RT followed by PCV and RT with concurrent and adjuvant temozolomide, that give the answer for temozolomide versus PCV. And in France, an ongoing trial, that is Volca, compared PCV chemotherapy with the radiotherapy followed by PCV chemotherapy with combination as the primary end.
Thank you, Mahesh, for the background. I think this is a complex topic and we need to discuss this in detail. So let's go to first the methods part.
Sir, if you could make me the host, I'll share the screen.
You can share the screen directly. Yes, you can go ahead.
Okay. I will coming to the methods and the results of this trial. The study design, it was an investigator-initiated trial. It was multicentric, randomized. It was unblinded trial. It was a phase 3 trial with the primary endpoint being the overall survival and the progression-free survival. What was the eligibility criteria? Here, the histological proof of a supratentorial WHO grade 2 astrocytoma or an oligodendroglioma or oligoastrocytoma, which was confirmed by the central path review before the randomization. 18 to 39 years of the age who underwent subtotal resection or who underwent biopsy, and more than 40 years of age if they had undergone biopsy or resection of any of the tumor, a KPS of more than equal to 60, and a neurological functional score of less than 3. The neurological functional status is if 0, if there are no neurological symptoms, the patient is fully active. 1, if there are minor neurological symptoms, but otherwise the patient is active at home and at work without any assistance. Moderate, in which the patient is active but requires some assistance. 3, when it is less than fully active and requires assistance. And 4 is severe neurological symptoms. The absolute granulocyte count had to be more than 1500, with the platelet should be in institutional range and the creatinine of less than or equal to 1.5. T-bill, SGOT and alkaline phosphatase should be within less than 2 times the normal limit. And the pre and the post-op MRI should be done with or without the contrast according to the availability of the center. And the patient should not have any chronic lung disease unless it is less than 60% of the predicted. The exclusion criteria, the patients who had tumors spread to the non-contiguous leptomeninges, gliomatosis cerebri, some synchronous cancers within the previous 5 years, except the cervical carcinoma or melanoma of the skin cancer. History of prior RT to the brain and the neck. History of use of prior chemotherapy in any setting. Active infection, pregnant or breastfeeding individuals. For evaluation, they did MRI and MMSC examination before cycle 3 and cycle 5 and completion of the therapy, and then every 4 months for the first year, then 6 months for the 2 years, and yearly thereafter. The IDH mutation analysis was done by IHC using a monoclonal antibody IDH1 R132H. The immunoreaction was scored as positive when the tumor cells showed cytoplasmic staining, and the staining of macrophages was not scored as positive. Here, they took 254 patients who were randomized. 128 were assigned the radiotherapy alone arm, and 126 were those who received chemotherapy plus radiation therapy. 2 and 1 were excluded from the trial. At the end, per protocol, 126 patients were eligible, out of which they were available for analysis in the RT arm, and for 125 in the RT plus chemotherapy arm. But we can see that there were many who had lost to follow-up in the RT plus chemotherapy arm and had discontinued the intervention. The patient characteristic in the RT alone and the radiation therapy, we can see that there was an equal distribution of the population with a median age of approximately 40 years. The male and the female were also equally distributed in both the populations. The neurological functions, mainly all the patients had neurological functional score of 0 and 1, and they had undergone primarily biopsy or some partial resection. And in the histopath, majority of the patients had oligodendroglioma and astrocytoma followed by it, and oligoastrocytoma followed by it. The IDH mutation was positive in approximately 60% of the patients in both the RT versus RT plus chemotherapy arm, and approximately 40% had no IDH mutation. And MMSE score for majority of the population was 27 to 30. Here, they were randomized into arm A radiation. The arm A radiation received 54 gray radiation, 1 point gray in each fraction, approximately 30 fractions over a period of 6 weeks. And the arm B received chemotherapy after the completion of the radiotherapy. That was 6 cycles. Each cycle was a 56-day cycle, where procarbazine was given at 60 mg per meter square from day 2 to day 21. CCNE lomustine was given at 110 mg per meter square on day 1. And vincristine was given at 1.4 mg per meter square, day 8 and day 29 of each cycle. The endpoints being the overall survival and the progression-free survival. The overall survival was from the date of randomization to the date of death or the last follow-up date on which the patient was reported to be alive. And the progression-free survival was from the date of randomization to the date of disease progression or death, or the last follow-up date on which the patient was reported to be alive. It was a study which was conducted from October 31, 1998 to June 27, 2002. Like I said, 254 patients were enrolled in this study. The median follow-up time was 11.9 years. And at the time of analysis, 67% had progression and 55% patient had died. The treatment in the RT alone, 98% of the patients received radiotherapy as per the protocol. And in the arm B, 93% patients received the RT, but only 56% of the patients were able to complete the chemotherapy. The median number of the chemotherapy cycles was 3 in the procarbazine arm and 3 received procarbazine. Four was for the CCNU and the VCR, median number of cycles. We can see here the IDH mutation analysis. It was detected in 78% of the patients, majority in the case of the oligodendroglioma, and 54% in the case of the astrocytoma, and 48% in the case of astrocytoma, which will help us further to analysis when we are looking at the prognostic factors. Now coming to the results, the progression-free survival, the median PFS was 10.4 years in the RT plus PCV arm versus 4 years in the RT alone arm. And the rate at 5 and 10 years would be at PFS at 5 years was 61% in the RT plus PCV and 44% in the RT alone arm. And correspondingly at 10 years, it was 51 and 21%. Here we can see the separation had started only after approximately 2 years of therapy. Now, in the various histological subtypes, as we can see in the grade 2 oligoastrocytoma, the RT plus chemotherapy arm was much better than the RT alone arm. Similarly, for the grade 2 astrocytoma, however, the separation of the curves was in the beginning in the case of grade 2 astrocytomas. And in the case of grade 2 oligodendroglioma, approximately 75% of the patients had a good PFS benefit. Now, coming to the IDH mutation analysis, we can see those who had IDH mutation who had received RT plus the chemotherapy had a better PFS than those who had received just RT. On conducting a multivariate analysis at 1 year of the follow-up, the following were identified as favorable prognostic variables, like oligodendroglioma was much better than the oligoastrocytoma and followed by the astrocytoma. And IDH mutation was an independent prognostic variable. Coming to the overall survival analysis, the median OS in the RT plus chemotherapy arm was 13.3 years versus 7.8 at the RT alone arm. And the rate at 5 years was 72% in the RT plus chemotherapy arm versus 63% in the RT alone arm. And correspondingly at 10 years, it was 60 and 40%. Now coming to the OS in various histological subtypes, the overall survival for grade 2 oligoastrocytoma was better than the RT plus chemotherapy, like we can see clearly versus then of the RT. Similar holds for the grade 2 astrocytoma and even for the oligodendroglioma. In the multivariate analysis of the overall survival at 1 year of the follow-up, we can see the oligodendroglioma arm did much better than the oligoastrocytoma, followed by the astrocytoma. The difference was not significant in the patients of astrocytoma. The better OS was in the patients who were less than 40 years of the age. And like earlier also mentioned, IDH was a independent prognostic variable. Coming to the toxicity, in the RT alone arm, the grade 3 and the grade 4 toxicity was less than or equal to 1%. The MMSE assessment in the RT or RT was with chemotherapy was higher than during the baseline in the during the first 5 years. In the case of the RT plus chemotherapy arm, the majority side effects were cytopenias, the bone marrow disorders. There were grade 3 toxicity in the form of neutropenia and thrombocytopenia. Coming to the nausea, GI disorders, it was maximum grade 3 toxicity was in the form of nausea and chemotherapy-induced nausea and vomiting, and fatigue and other weight loss and equally distributed. That's all. Thank you.
Thank you, Aarti. So now we'll move to the discussion part. You can stop the screen sharing. Arvind, you can go ahead. Arvind, you can share the screen.
Sir, Dharampal will be presenting, sir.
Okay, okay. Yes.
I am sharing, sir.
Yeah.
Means yes. Uh,
Yes, it's visible. You can make it full screen and start.
okay. So I am presenting the discussion part. Radius. So that already discussed, the low grade glioma comprise 5 to 10% of all CNS tumor. Seizure is the main common symptom in low grade glioma. The median duration from onset of seizure to 17 months. Initial approach to all patient with glioma of high grade is maximal safe resection depending upon the location and extent. Only partial resection and even just a biopsy may be done. Prognostic factor for PFS or OS in patient with grade 2 glioma include age, histology, tumor diameter, tumor crossing midline, neurological status, or PS prior to surgery, and the presence of certain molecular marker. Median survival on basis of histology is astrocytoma of 4.7 year, oligoastrocytoma is 7.1 year, and oligodendroglioma is better, OS 9.8 year. On basis of age, in less than 30 year, OS is not reached. 30 to 49 year is 5.5 year. In more than 50 year, it's 1.6 year. On basis of surgical resection, 5-year survival. In gross total resection, it's 85%. In subtotal resection, it's 64%. In biopsy, it's just 43%. So systemic review show that GTR was significantly associated with decreased mortality and lower risk of disease progression up to 10 years after treatment compared to STR. Maximum safe resection also delay or prevent malignant progression and recurrence. Low-grade glioma patient with residual tumor volume less than 10 ml had a recurrence rate of 15% compared to recurrence rate of 40%. Is greater than 10 cc. So low-grade glioma divided in low and high-risk group. This is the for high-risk group, the subtotal resection and biopsy, age more than 40 years, large preoperative tumor volume more than 4 centimeter, presence of neurological deficit and wild-type IDS mutation. These are high-risk group. Where we can observation alone post surgery. This is already discussed that we patient who undergo gross total resection with IDS mutant grade 2, age less than 40, tumor size less than 4 centimeter with oligodendroglioma histology and also astrocytoma. After the patient who kept on typically MRI with contrast 3 to 4 months, age active surveillance. So these are the trial for low-grade glioma post-surgery, adjuvant RT में early versus delay RT, URTC 22845, high dose versus low dose radiation, radiation versus chemotherapy, IDH inhibitor indigo trial, radiation versus chemotherapy, compare adjuvant PCV versus temozolomide and adjuvant temozolomide catenon trial. So this trial is already discussed. Long-term efficacy of early versus delay RT for low-grade astrocytoma and oligodendroglioma in adult. 157 patients were assigned early radiotherapy and 157 in control. Median PFS was 5.3 year in the early radiotherapy group and 3.4 year in the late RT group. And p-value is less than 0.001. Or OS was similar between group. Median survival in the RT group was 7.4 year versus 7.2 year. Seizure control was better in the early RT group. The majority of patients in the no therapy group received RT at progression. Among patients who underwent surgery at the time of recurrence, approximately 2/3 patients were high grade in each group. The IDS mutation status of the tumor of patient in study is unknown. So conclusion was the trial is early radiotherapy after surgery length the period without PF progression, but does not affect OS because quality of life was not studied. It is not known whether time to progression reflect clinical deterioration. So based on this trial, we can kept on observation the patient with low risk. Final report from internal NCCTG, a phase 3 randomized clinical trial of high dose versus low dose radiation for adult low grade glioma. So this trial was done for the dose of radiation. So between 1986 and 1994, 203 patients with supratentorial low grade glioma were randomized to 50.4 gray in 28 fraction versus 64.8 gray in 36 fraction. So high dose radiation did not improve 15-year OS versus low dose radiation. So OS was significantly better for patient with preoperative tumor diameter less than 5 centimeter and baseline MMSE more than 27 and who underwent total resection. PFS was improved for patient with oligodendroglioma versus astrocytoma, preoperative tumor diameter less than 5 centimeter and gross total resection and patient with baseline MMSE more than 27. So long-term follow-up indicate no benefit to high dose over low dose radiation for low-grade glioma. Cognitive function appear to be stable after radiation as measured by MMSE. So based on this trial, we use load 50.4 gray radiation. Next trial is RTOC 9802, a phase 3 study of radiotherapy with or without PCV. So there is two group in high risk group age more than 50 after subtotal resection in one arm RT alone and one arm radiation followed by PCV 6 cycles. So OS was 7.5 year versus not reached, 5 year OS 63% versus 72%. Median PFS 4.4 year versus 5 year PFS was 46% versus 63%. So low-grade glioma CTRT saw OS benefit over a lone RT group. Treatment effect was largest in patient with IDS mutation and oligodendroglioma histology. The difference in survival cannot be explained on the basis of treatment after tumor progression, because after tumor progression, RT therapy alone group have shorter time to progression and there is more therapeutic intervention after progression in RT alone group. Separation of PFS curve began 2 to 3 years after randomization. 25% of patients in each group had disease progression by then. Difference in outcome become apparent with each histology category after 50 to 30% of patients had disease progression. OS separation of OS curve become apparent with each histology diagnosis category. Delayed separation in patient with IDH1 R132H mutation. Comparison with other trials. So two phase 3 trial are show similar result. Patient with 1p19q co-deletion IDS mutant or both had a longer PFS and OS with RT plus chemotherapy. Even in patient with 1p19q co-deletion, the separation of the PFS curve did not begin until approximately 25% of the event had occurred. We cannot determine whether CTRT group was beneficial for patient with a wild type IDS mutant because of the small number of events in these patients. So why IDS mutant glioma have better prognosis? So IDS mutant are associated with CpG isolate methylator phenotype and most tumor with 1p19q co-deletion also have IDS mutation. So DNA repair enzyme that repair alkylator damage such as O-methyl guanine DNA methyltransferase are silenced by promoter methylation. So which result in greater sensitivity to alkylating agent. Toxicity, frequency and severity of toxicity are greater in the CTRT group. Most toxic effect were grade 1 or 2, grade 3 or toxicity effect were uncommon. Late toxic effect due to radiation in the CNS reported in 22% of the patient, grade 1 event in 50%, grade 2 event in 6%, and grade 3 or 4 in less than 1%. So patient treated either with RT alone or with CTRT group had a significant higher average MMSE score during the first 5 years after randomization. The initial report that provided the efficacy analysis is specified in the protocol below. At the time of analysis, 38% of patients had died with a median follow-up time of 5.9 years. we cannot determine whether CTRT group was beneficial for patient with wild type tumoral IDS because of a small number of events in these patients. Analysis was not done on basis of molecular status, limited data on quality of life post radiation. So there is another trial on vorasidenib in IDS1, IDS2 trial. So this is double-blinded phase 3 trial. We randomize patient with residual or recurrent grade 2 IDS mutant glioma who undergo no previous treatment other than surgery to receive. In arm 1, oral vorasidenib 40 mg OD, and arm B placebo was given. PFS was significantly improved in the vorasidenib group as compared with the placebo group. Median PFS was 27.7 months with this drug, 1 month in placebo group. So, so this is the graph showing PFS benefit with vorasidenib in low-grade glioma. This is another trial, temozolomide chemotherapy versus radiotherapy in high-risk low-grade glioma, phase 3. Low-grade glioma with at least one high-risk feature, eligible patient will randomize to receive either performer radiotherapy to 50.4 gray for 1.8 gray once daily, 5 days per week, or dose dense oral temozolomide for 12 cycle. At a median follow-up of 48 months, median PFS was 39 months in the temozolomide group and 46 months in the RT group. Patient with IDS mutant and non-co-deletion treated with RT had a longer PFS than those treated with temozolomide. Grade 3-4 hematological adverse occur in 14% of patients treated with the temozolomide and less than 1% treated with RT. Grade 3-4 infection occurred at 3% of treated with temozolomide. Significant difference in PFS in patient with a low-grade glioma when treated with either RT alone or temozolomide chemotherapy alone. So this is Catalan trial for grade 3 tumor, concurrent and adjuvant temozolomide chemotherapy in non-co-deletion anaplastic glioma. So they have 4 arm. In one arm, only radiation alone, and one arm RT plus concurrent temozolomide, and one RT plus adjuvant temozolomide, and one arm so temozolomide. So the analysis declared that concurrent temozolomide median OS was 66.9 months with concurrent temozolomide versus 60.4 months without concurrent temozolomide. P-value is 0.76. By contrast, adjuvant temozolomide improved OS compared with no adjuvant temozolomide, 82.3 months versus 46.9 months. So interpretation of Catalan trial is adjuvant temozolomide chemotherapy, but no concurrent concurrent temozolomide chemotherapy was associated with a survival benefit in patient with 1p19q non-co-deletion anaplastic glioma grade 3 tumor. So this is another trial, PCV versus temozolomide chemotherapy for patient with low-grade glioma, a systemic review. So Tal et al. Reported that a median OS of 120 months when using PCV alone. And Buckner et al. Reported a median PFS of PCV alone was 32.5 months. PFS when administering PCV combination with RT was 124 months. Adverse event for patient with low-grade glioma treated with for toxicity was 41.6 and 6% for 20 patients respectively. In contrast, patient group treatment group 0.8% grade 3 and 0% grade 4 toxicity. So this is the trial which showing overall OS and PFS benefit in low-grade glioma with the RT plus PCV, RT alone and RT temozolomide, and followed by temozolomide. 14 study assessing survival outcome with temozolomide. Of these 6 study reported survival data. A median OS of 116 month was found when administered temozolomide on its own. A median 5-year OS of 57.1 was reported when combined temozolomide and radiation. An open label phase 3 European Canadian intergroup study saw median PFS for RT alone was 46 months, while median PFS for temozolomide alone was 31 months. One study reported median PFS of 54 months when administered temozolomide in combination with radiation. So Kalossi and Collegia reported that patient rated with temozolomide chemotherapy tolerated it well with 7% grade 3 and 8% grade 4 myelosuppression. So conclusion is tumor with an unfavorable natural history such as with intact 1p19q and wild type IDH mutation, RT and temozolomide plus adjuvant temozolomide may be the best option with less toxicity. Conversely, patients with biologically favorable high risk low-grade glioma are likely to derive the most benefit from RT followed by adjuvant PCV. So this is the another trial radiation and chemotherapy for high-risk lower-grade glioma, choosing between temozolomide and PCV. The majority of the patients with high-risk lower-grade glioma are treated with single-agent temozolomide and radiotherapy, despite 3 randomized trials showing a strict OS benefit with adjuvant PCV, chemotherapy and radiotherapy. The article aimed to evaluate the evidence and rationale for the widespread use of temozolomide instead of PCV for high-risk low-grade glioma. So there are the results. So there are other relevant prospective and retrospective study comparing temozolomide with PCV, nitrosourea, recurrent or primary low-grade glioma. So there are three prospective trial which are and 0A04 with et al. Prospective randomized trial. They included anaplastic glioma which favor PCM, PCV, RTOG 9813 trial prospective randomized trial. They included anaplastic astrocytoma grade 3 tumor, which resulted in no significant improvement in OS or TTP between arm temozolomide better tolerated. So this favor temozolomide prematurely stopped due to poor accrual, not PCV. So other two retrospective trial, Leishman et al. In 2011, they included anaplastic oligodendroglial tumor. Comparison is there CT-RT, RT alone and chemotherapy. So the result was median TTP longer for temozolomide alone in 1p19q co-deletion. So this trial is favor PCV. And then another study, retrospective, Bredes et al. In 2006, retrospective, anaplastic astrocytoma population. Adjuvant chemotherapy, PCV versus temozolomide following surgery and RT. So there is no PFS or OS difference between PCV and temozolomide chemotherapy. Favor temozolomide given toxicity profile, small number, and retrospective data. So this is the take-home message that low-grade glioma with low risk can be observed with active monitoring. Delayed RT in the setting does not appear to detract from overall survival, while it does postpone the potential toxicity of therapy. IDH mutant glioma responds better to CT-RT than wild-type IDH. Grade 2 glioma patient treated with RT plus chemotherapy saw a PFS and survival benefit compared to those who received RT alone. Emerging approach IDS targeted therapy need FDA approval and further comparison trial for establishment and standard of PCV in favorable molecular status. Consider use of temozolomide in unfavorable molecular status with lower toxicity. The ongoing PODEL trial result to compare RT plus PCV versus RT plus temozolomide. Thank you.
Thank you, Dharampal. So it was good that you could review the most of the relevant articles and topics related to both radiation and adjuvant therapy for both PCV and temozolomide. So these are the main 5 to 6 articles which are very relevant for treatment of low-grade or anaplastic gliomas, and these are important for every resident to be understood. So I think I will first take comments from Nandini ma'am. Nandini ma'am, your take on this article and what are the important drawbacks of this article and how should it be interpreted in the practice?
So basically, this article was one of the first to determine. This was a study which we have to remember was designed in the 1990s, and it was actually conducted many years ago. But this was one of the main pivotal articles that showed that there is a established role of giving some adjuvant therapy, and there are two more papers which were designed around the same time, which looked at grade 3 also, and 3 or 4 of this which Dharampal has discussed, that is the 9802, 9402 and the EORTC, showed the role of chemotherapy. Previously in low-grade gliomas, it was either you observe if there is a gross total resection and a low risk tumor, especially like an ODG. But we all know that even despite them being grade 2, there are multiple patients who fail, especially with the poor risk features like age, histology of astrocytoma, and the ones which are IDH wild type. Now, this was the first paper that showed definitely there's a PFS benefit, and also there is an OS benefit, especially in the 1p19q co-deleted subgroup. So that is the main message of this paper, that there is a group of patients who definitely in the grade 2. So this paper, not to be mixed with the other articles that Dharampal has discussed, is mainly looking at only grade 2 gliomas, and they looked at 2 or 3 high risk features. One is whether they had subtotal resection, which is a poor prognostic factor, and a older age, which is a poor prognostic factor. And this established that in grade 2, there is a role of adjuvant PCV in addition to RT. And there are 2 separate trials of EORTC and RTOG 9402, which looked at a similar thing of grade 3 astrocytoma oligodendrogliomas, which had anaplastic features. They also established that PCV has a benefit in these grade 3, which are inherently high risk. So that is the main message. The main limitations of this study is because it was designed in that era. They have included a little bit of a heterogeneous population as compared to the current WHO 2021 classification, which strictly defines that you have to have a 1p19q co-deletion to define as an oligodendroglioma. Otherwise, it is now in the current classification, which is the integrated pathological and molecular classification. You can't label any tumor as an oligodendroglioma unless they are IDH mutant with the 1p19q co-deletion. All others, even if they are morphologically looking like ODG, they are not to be treated as an ODG because they do not biologically behave like this IDH mutant 1p19q co-deleted. So that is the limitation here. Of course, that time our knowledge and the evolution of molecular understanding of gliomas was not as well developed as now. So this study was designed maybe 25 to 30 years back. So at that time, we considered both patients who had oligodendroglioma morphology, whether they were 1p19q co-deleted or not co-deleted, who were included. And that is why you can see the differential in the outcomes, where the IDH mutant shows much better outcomes and the 1p19q shows much better outcomes. That is because those are now typically defined as ODG, and all the others which may have a oligodendroglial morphology or a mixed morphology, but without these molecular features, are not to be considered as an ODG. So that would be a potential limitation of the study.
Thank you, ma'am. Another point is the perceived toxicities with PCV protocol. So PCV protocol might lead to some severe toxicities, myelosuppression. Your take on that and how to tackle that in the real practice?
So there are, I think, 2 things. One is the toxicity of the PCV definitely is significantly higher than temozolomide. That is why, despite all these studies showing that PCV was a better adjuvant therapy in ODGs, a lot of extrapolation and small phase 2 studies and other studies started using temozolomide, looking at its benefit. But so far, temozolomide has not, like in ODG histology, shown a significant, strong, robust data for benefit, but we use it as extrapolated data. Toxicities with PCV significantly is myelosuppression because of both procarbazine and CCNU, which 2 alkylators which we give. And of course, it is difficult to manage. There are, even in our top study where we looked at the 2 and we analyzed the first 50 patients data just to see the safety, we saw that around 2/3, around 68% of those patients had dose delay reductions, and some 80% had dose delays in the PCV arm. So it is challenging, but when many people say PCV challenging, we also must keep in mind that we also administer a lot of other more toxic therapies like DCF and other things. So if we can carefully manage those kind of regimens, definitely PCV is a manageable regimen. What we need to do is counsel the patient properly and monitor closely for the counts. And once you give multiple patients PCV, you tend to know that usually the count drops in the second month. That is, in the RTOG schedule, the second month doesn't have any active chemotherapy. The lomustine is given on day 1, and the procarbazine is given from day 8 to 22. That is another 15-day period, and then there's only a single vincristine dose at day 29. It is after this day 22 till day 56, which is essentially a chemo-free period, where you will see the toxicities. And those are the times that you should call the patient to monitor counts, especially if their patients have had grade 3 or grade 4 myelosuppressive events in the previous cycle. Because many times patients want to go home, or they probably don't want to visit the hospital during that chemo-free period. So if you start giving more and more PCV, we realize that with careful monitoring, it is possible to deliver PCV safely. At least in our setting, we have not had any mortality related to PCV. We've had only one FN so far. So though there are multiple grade 3, 4 events, especially thrombocytopenia and neutropenia, they are, I think if carefully and properly monitored, they can be managed and we can deliver. So I don't completely agree with the principle that we should completely eliminate PCV just for the hematological toxicities. But another important and troublesome toxicity is the neuropathy, which we see in most patients by the end of the third or fourth cycle. And many times we have to either dose reduce vincristine or eliminate it altogether, because they do develop significant neuropathy. So there is also a lot of debate on the role of vincristine in this regimen. So that is not very clear. So that is also a challenge that we um, have to deal with the peripheral neuropathy. Long term, these patients don't tend to, at least the ones in our trial so far, in the 150, 160 odd patients that we had, one third our PCV arm, have no delayed toxicity. We have not encountered any kind of long term hematological issues in most of these patients. So they do okay. It is the acute intensive monitoring that is needed.
So that is important. So this regimen is deliverable, but yes, requires adequate and proper monitoring and proper counseling. So that is the crux. And we have seen that this is a regimen which has clearly showed us overall survival benefit of 5 years. We learned from Kumar sir that this is one of the trials which showed a so significant overall survival benefit, increasing the outcomes overall survival from close to 8.5 years to 13.5 years. So that is a regimen which has clearly showed a benefit, and we need to select the patients well and manage the patients well, and so that the toxicities are managed well. So this is an important article. I think it is very pertinent to understand the benefit of the PCV protocol and where to utilize it, and how to adapt it and how to dose reduce it. So it requires monitoring, but it is. Any comments from Kumar sir, if you are available, sir? I think sir is clear. Any comments from any of the residents or any fourth years?
That PCV is more beneficial for the
Arvind, they are not audible. At least I can't hear.
Yeah, your voice is breaking, Arvind.
Sir,
Yes.
no separation of PFS and OS graph until 2 to 3 years. How we can
You explained, Dharampal, why was there no separation of the graph? Why you expect the graph not to separate? In this study, not in other papers,
it
in
means
this particular study.
The no separation of the graph until 2 to 3 years. It may be of because this benefit is because of radiation alone.
So basically, what is the tumor population you're dealing with, and what is the natural history of that disease?
So we are dealing with low-grade glioma with good biology disease.
So that is what is the median survival? Suppose you don't give chemotherapy, and you only operate or you only give RT. You have also discussed no observation in grade 2 glioma. So what is that
Yes,
like? What is the current treatment paradigm? What do you do in grade 2 glioma? Currently, suppose a patient comes to you.
ma'am, if there is a gross total resection and patient is asymptomatic, low-grade glioma with a good young patient, we will kept on observation and start treatment, start radiation
Nee.
on progression.
So if the patient has say grade 2 astrocytoma with a gross total resection, would you want to keep that patient on observation? Is that what we do commonly?
Yes, ma'am, we kept, if there is no high risk feature, we can kept, and patient is asymptomatic, we can kept on observation.
This is a astrocytoma histology I'm is asking.
Astrocytoma?
Grade 2 astrocytoma.
No, ma'am.
In that Pignati criteria, what was discussed? What are the 6 or 5 criteria which he pooled and analyzed are poor prognostic factors?
There is histology of oligoglioma.
So basically, if you have a grade 2
you-
astrocytoma, very rarely, sometimes there are very few cases where we keep under observation and not offer adjuvant RT. Most of the time, these patients go for adjuvant RT and adjuvant chemotherapy because astrocytoma inherently is an aggressive histology. It is the ODG patients whom you are going to consider either in select cases where the age is less than 40, none of the high risk features are there, and there is a complete gross total resection. Those are very select cases where you can offer them observation. Other option is to offer them maybe adjuvant RT alone without chemotherapy. But if they have any of the high risk features which has been discussed in this paper and also in the Pignati criteria, actually some of the criteria in Pignati are ultra high risk, like crossing the midline or a tumor centimeter more than 6 centimeters. Now those are definitely going to have residual disease. So that anyway disease encompass those tumors. But all the other high risk tumors, you will definitely give adjuvant therapy, maybe adjuvant RT, and if it is having those high risk features which are defined in this trial, then adjuvant PCV. So there are a select group of patients only who will be under observation, not everybody. And this is generally for ODG. And in today's era, the ODG will be defined as those who have IDH mutation with 1p19q co-deletion. The reason probably the curves did not separate early is because of this low grade biology that you have taken. So the benefit was seen later on, and also the natural history is that if you have an ODG, they generally don't progress in the first 2 to 3 years if it is a pure ODG. So that is why probably the curves have not separated in these tumors in this group of patients, and then slowly the separation has happened as per the natural history of a grade 2 ODG, which then after 3, 4, 5 years the patients will start progressing. So a progression-free survival of ODG is around 4 to 5 years with surgery alone or RT or surgery followed by RT. So that is why you don't see the benefit in the initial years in these tumors, in this paper particularly.
So it's, I think Dharpal, you must have understood now. So it is the tumor biology itself,
sir.
which is leading to. So I think this topic is an important topic, but most of the times it looks complex. That is why it is missed. Hopefully, all the residents will be able to understand the importance of selecting the patients, how to give PCV, when not to give, when to give. All these are the important points, and these needs to be understood closely.
Sir, in which cases we will mostly prefer temozolomide over PCV? In which low grade, madam?
So Nandini ma'am, Sayak is
So
asking.
temozolomide versus PCV, actually in the low grade there are studies which looked at it. There's a phase 2 study which looked at temozolomide versus RT and RT alone versus RT temozolomide. No one has actually published data of temozolomide versus PCV. So the CODEL study now, after CODEL showing that temozolomide alone is detrimental and you have to give RT plus temozolomide, they have modified their study design and now they are looking at temozolomide plus plus RT versus PCV plus RT in ODG histology. In the other histology, that is in and astrocytoma histology, there are studies which show that temozolomide is beneficial, but again, it is compared to temozolomide plus RT. And the initial study, like this RTOG 9802, did not differentiate patients whether they were astro or oligo. They took, they took patients with oligodendroglioma and a mixed histology as well. And there are some studies which included grade 3 tumors of both the histology. So which study shows that temozolomide is better? There is no study right now that has shown better results of temozolomide versus PCV in oligodendrogliomas. There are two ongoing studies. One is our study, which is looking at all high-risk tumors in grade 2 and grade 3 tumors, irrespective of histology, and randomizing them to temozolomide PCV 2:1. That is, two patients will go to temozolomide versus one as a PCV, and PCV is considered as a control, and the CODEL study. So then we'll get to know whether it is better than not better. There is another study called CATNAN, which looked at temozolomide and its role in non-1p19q co-deleted. And in those tumors, they have shown that adjuvant temozolomide has a survival benefit. They also looked at the role of concurrent temozolomide. So they had 4 arms: RT alone, RT plus concurrent, and adjuvant, and RT followed by adjuvant without concurrent. And they showed that in that initial report of this CATNAN, they have shown that the adjuvant part of temozolomide has a better, more importance than the concurrent RT, what you give concurrently with RT. And this was in those tumors, like astrocytic tumors without the 1p19q co-deletion. So in those tumors, you will prefer to use, you could prefer, say that temozolomide may be preferred because the data for temozolomide in the 1p19q co-deleted is not very robust. But many people extrapolate whatever data is available and use it in both histologies. So there is no answer that temozolomide is better than PCV in a particular histology, because no one designed the studies that way. But in based on the recent CATNAN, in the non-oligodendroglioma molecularly and histologically group, temozolomide, especially with the adjuvant 12 cycles, has a survival benefit. So maybe you would consider temozolomide in those tumors, astrocytic without a 1p19q co-deletion, and of course glioblastoma, where temozolomide has proven efficacy. And PCV so far is preferred in the ODG histologies, but comparing the two chemo, the data is still not available, not mature.
Thank you, ma'am. And also one point which is important here is in adjuvant settings in grade 2, grade 3 glioma, whenever temozolomide is utilized, the data is used for 12 cycles, correct, ma'am?
Yes, yes, sorry.
Yes,
12
yes.
cycles.
Yeah, so it is not like grade 4 glioma where 6 cycles of adjuvant temozolomide is given. In grade 2, grade 3, wherever you are utilizing temozolomide, it has to begin for 12 cycles. So this is the difference from the grade 4 glioma. Okay, thank you, ma'am. Thank you to the presenters. Mishra sir, any final comments?
So I think this is a nice discussion. We clarified the number of cycles of temozolomide, which is very important for this type of setting, 12 cycles versus 6 cycle, which is used in low grade. One more thing, it is we need to understand this regime very thoroughly, because it is a 6-weekly regime. Basically, most of the solid tumors are using 3-weekly or 4-weekly. So we need to practice before practicing PCV. It is very good regime, but we need to just go through the regime very properly. It is a 6-weekly regime, not a 3 or 4-weekly regime, to avoid any toxicity.
Yes. The proper patient counseling is very much required.
And we can avoid this regime in poor performance status, non-compliant patients. So we need to select the patient properly before starting this regime.
Yes. Thank you, sir.
Thank you, sir. So just to keep just one last comment is why Akhil was trying to emphasize the importance of this paper is just to remember that grade 2 gliomas, though they are the less common glioma, they are the ones which you see in very young patients between 20 to 40 years. So the whole idea of presenting this in the journal club is to understand that adjuvant therapy improving survival in years happens in very select tumors. We don't see this data. And the important thing is you look at the study population and the age group of patients that you're dealing with, and in these patients, this data is very meaningful, because if you're a 25-year-old with a grade 2 glioma, for you having a survival of 5 or 10 years more is much more important than the PFS and the OS, of which we talk in months. So that is why you should understand the importance is not just the trial data, it's the setting of the disease and the kind of patients that you're going to treat. So that is what Akhil also was trying to emphasize when the discussion started.
Thank you. Thank you.
Thank you, everyone.
Thank
Bye.
you. We can end now. Thank you.